Hello, everybody. Hope life is treating you gently in these pretty rough times. Welcome to this premiere of a series of case-based webinars organized by WINFOCUS. There's no need to say how there is a need in this difficult period to discuss, to share, to have opinion guidance available to clinicians on the use of point-of-care ultrasound. And today we're in fact focusing on point-of-care ultrasound use for COVID-19 patients with respiratory failure, acute respiratory failure. And we're lucky enough to have Alberto Goffi. Welcome, Alberto, and thanks for joining us. How are you doing?
Welcome, everyone. Thanks for joining and thanks for inviting me.
And also thanks, Anthony Dean, for helping us carrying this through. Thanks to Davide and Queen for setting up all the logistics. So basically, Alberto, just a brief introduction, is a staff physician at St. Michael's Hospital in Toronto. He is assistant professor at Toronto University and the Department of Medicine and Interdepartmental Division of Critical Care Medicine, again in Toronto. For those of you who don't know him, Alberto's interest is in neurocritical care and point-of-care ultrasound, and specifically on the clinical utility of PoCUS in critical care and teaching, and also, let's say, developing strategies for achieving competence in point-of-care ultrasound. Alberto has traveled extensively in the world, teaching PoCUS, also in developing countries, and he publishes regularly on the topic. Just a few notes to let you know who Alberto is. The way the nurses in his ICU, the way they named him, or better say, the way they named the ultrasound system they were using, it was Alberto's second love. And why the second? Well, because the first was basically died due to an excessive use and consuming use by Alberto himself. Alberto, you can confirm this.
Yeah.
So please, Alberto, introduce us to the topic.
Years ago, they actually brought.
Yeah, they bought a new one, which is the one you're using now. Great. So it's going to be a two-parts webinar. And before I give you the mic, just a technical note. If you want to make questions, please use the Q&A feature of the Zoom platform you're using. If you have technical issues, please use the chat, and we'll try to answer on the fly. But in any case, in the end, there's going to be time to discuss, and we'll be happy to welcome your questions. Alberto, please, the mic is yours.
Thank you, Gabriele. I'm going to stop the video, so hopefully this is going to improve the quality of the transmission. It's a real pleasure, Gabriele, being here today. Thanks, Anthony. Thanks, Davide. Thanks, everyone, for joining. I saw from the audience there are a lot of very well-known experts in point-of-care ultrasound, so a little bit of daunting experiences presenting in front of this panel. As Gabriele mentioned, feel free to interrupt anytime, ask questions to the Q&A, to the chat. We are trying to make this as much as possible interactive and to really benefit from everyone's experience. I'm pretty sure that many of you have seen more COVID patients than I did, because fortunately Toronto was pretty spared so far. We had a peak, but nothing compared to Europe, US, or South America so far. Okay, so in terms of disclosures is that I collaborate with other societies outside WINFOCUS. I'm the vice chair for the SCCM Ultrasound Committee. I'm a member of the Canadian Critical Care Ultrasound Consortium, but none of this affiliation is going to affect my presentation. The only really conflict of interest is my daughter, that you can see. She was 1 year and a half and she was already playing with a phase array probe. And this is unfortunately something that runs in the family, I believe. As Gabriele mentioned, when we started preparing this webinar, we realized that there was a lot of talk about it. And we therefore decided to split the webinar in two parts. The first part is what we're going to focus today. and there's going to be a second webinar. So they're truly focusing on the use of point-of-care ultrasound in the management of patient. We're going to discuss about the recruitment maneuver. We're going to discuss about proning and other critical intervention that we do in the ICU. The first part that we're going to discuss today is going to be focusing on the use of ultrasound for diagnosis. Of course, diagnosis of COVID pneumonia, and then the detection of complication associated with COVID-19. And we will try to do this through a mix of case description and review of the incoming literature, because really every day there are new articles published on the topic. So question number one is that easily say, can ultrasound diagnose COVID-19 pneumonia? Can we use this to diagnose reliably and effectively with specificity and sensitivity COVID-19 pneumonia? Well, let's start with two typical cases. For the ones that are not familiar with scanning protocols, this is the terminology that I'm going to follow during my presentation. You see here, there are many scanning protocols described. So I usually use these 8-zone or 12-zone protocols, where I essentially divide the chest in anterior, lateral, and posterior zone, and I divide the chest in superior and inferior. So every time you're going to hear zone 1R, for me means that is ventral zone, so anterior zone, superior. When you hear about zone 6, it's going to be posterior, usually at the base of the lung, so in the costophrenic angle, and can be L for left or R for right.
Alberto, just one question.
Yes.
Are you scanning all intercostal spaces when you refer to a zone? That's something people may want to know.
Usually I do as much as possible. And again, I think is that the vast majority of the literature is clearly saying that what you do is that you scan as much as possible the entire area that you identify as zone 1, and then you focus on the worst for scoring purposes.
Good.
For other applications, I really scan as much as possible. It doesn't take much, even if you scan all the intercostal spaces, to identify subtle findings, especially in the context of, for example, suspected pulmonary emboli when I'm looking for pulmonary infarcts, or other more scattered findings. So the answer is yes, as much as possible, I try to scan everywhere. What do you do, Gabriele?
Well, I do the same, I would say. But it depends on the protocol. I mean, or the situation. If you're going very fast, you could do the simple. I mean, the same way you use the stethoscope. Just put it in the center of the zone and get the finding there. But especially, I think when we're talking about COVID and the kind of pneumonia it is, especially in the early phases, scanning all intercostal spaces is so important to pick up also the findings in known very severe pneumonitis. This is what I believe.
Perfect. Okay, so let's start with the first case. This was a gentleman that I saw on a Saturday morning, early morning, back in April. Typical risk factors: male, in late 50, with history of diabetes, hypertension, that comes to the emergency department with severe respiratory failure. Essentially, we intubated in the emergency department, brought out to the ICU, and rapidly deteriorated for a severe respiratory failure. As you can see from the chest X-ray and from the CT scan, quite typical findings for COVID pneumonia with the peripheral ground glass opacity and crazy pattern and basal consolidation. So let's have a look at how his lung ultrasound look like. And again, here we are seeing anterior zone, again, right anterior superior,